Very warm welcome to one and all to the IC94 Trauma in Ophthalmology Practice Pearls. Trauma due to various causes like fall, etc., accident, assault or occupational injury, fall, etc. often involves the eyeball and adduxa. In the clinical practice, it is extremely important to know the various examination techniques related to such cases of trauma. A thorough examination helps in the classification and planning the management course. Among the various manifestations, traumatic hyphema is a very common condition that is practically important. Traumatic glaucoma can be both acute or chronic, open angle or close angle type. Another equally important clinical presentation is that of traumatic optic neuropathy, which can be vision threatening and needs prompt response from the treating doctor. Most of these traumas present to casualty and end up as medico-legal case, and thus special emphasis be taken in documenting this meticulously to avoid litigation. Many times doctors may be called as an expert witness in courtroom to present these clinical findings. So first we have Dr. Sudha V. Madam for examination techniques in ocular trauma.
Thank you, KSOS, and thank you, Dr. Raghu, for giving me this opportunity. This is a very general talk. We're just starting with how to examine a patient who comes to you in casualty with ocular trauma. So the first thing that we know that when he comes to casualty, the main thing that we are supposed to look is the first aid problem. You need to look at the ABCs. But for related to ophthalmology, there are two things I would like to say. This is okay. This is seen by most of the casualty person will see it. But what we need to see, there are two things which you see. If this patient is under neurocare, please do not dilate the pupil, because that is important. The neuro people follow up this patient based on the pupil. So do not do that. Second, if this is an unconscious patient and you need to check ocular movements, the one way to do it is doll's eye movement. Again, do not do this if the patient has a neck injury. So neck or spine injury. So these are the two important things we must keep in mind, because we just go in and examine the patient. That should not be how it is done. You have to be sure that you get clearance from the other departments before you go on to do something like this. So what are the do's that you must do? Make the patient comfortable. There is no emergency immediately that you have to go and open the eye and see it. So make the patient comfortable. Prevent any further expulsion of contents. So keep the bed rest up, head elevation. And if the patient you feel requires a general anesthesia, do not ask him to eat or drink anything right now. And of course, we do the general general OT prophylaxis of tetanus and document the medico-legal case. There should be, again, don'ts. Do not apply pressure. Please do not rush and open the eye. Do not check the intraocular pressure until you're very sure that this is not an open globe. And something else, there are a lot of tissues coming out, will be a lot of bleeding. You will try to clean it up and try to debride the tissue. Without knowing what tissue it is, do not debride. Do not debride any lid contents. Do not debride any ciliary body projecting. Remember that most important is you have to first examine. Do not touch or manipulate the eye too much. Things like LASIK flat dislocation, don't try to remove it. You don't know what it is. Just don't try to pull it out. Don't try to pull out a foreign body which is sitting into the anterior chamber. We all know this, but it is just that when you go to the casualty and see the patient, we just try to clean it up. So that is something which we must try to prevent. Before all this, rule out bradycardia, heart block, nausea, vomiting, everything. So basically make the patient comfortable. And you have to look at the pupil, you have to look at the shallow anterior chamber. If there is a peaking of the pupil, we must suspect that there is a occult globe rupture. And the other emergency that we must know is whether there is bleeding behind the eye, which is increasing the pressures and which we may need to do a lateral canthotomy before we can completely examine. Otherwise, we will have a compression in the orbit, because the orbit is a closed entity. So the preliminary examination, even before you take the history, first thing when he comes to casualty, it is something like triaging. You need to know if you want to go into that emergency condition, you need to do anything. So you have to assess the both eye, even if the eye injury is unilateral, and document it. And prevent the active bleeding there. Again, prevent, it is just try to stop it, but don't apply too much pressure, don't do much manipulation. And of course, chemical injuries, you have to first irrigate before you do anything else. So this is the preliminary part. Then you need to classify. Now trauma is, mechanical trauma especially, is now classified so that we know what the prognosis is. And the classification is based on this. It is the type of trauma, grade of trauma, RAPD presence or absence, and zone of trauma. So the type of trauma is based on history. So we need a proper history. Grade of trauma is based on what is his presenting vision, because that is the prognosis. And the presence and absence of RAPD gives you the trauma score. And the zone of trauma gives you what is it a dangerous area. So the focused history is important. So once you've settled the patient, made him comfortable, ruled out any Valsalva problems, then you ask him the history. So you ask him the time, place, the nature, the usual history which we will ask. But more important is what is the treatment he's got before he reached us. Most often, somebody must have pulled him up from an RTA place and brought him here. So we need to know, has he placed any drops? Has he done anything before he has brought him? Maybe he's given some pressure bandage. We need to know this. Has he applied any atropine ointment? Some of them do that. So I've got a patient who had actually got atropine ointment. We didn't realize this. That was because it was not an atropine ointment. He was given an Ayurvedic drop. But inside that, there was atropine. So if you're not sure, this pupil was dilated. We were looking, what is this third nerve palsy? What is this? It's actually simple because the Ayurveda person had put a drop. And then only later we realized it. So examination, always make sure that you examine the patient in very bright light. So open lobe injuries, you have to examine only under OT. Take him to OT or at least a place where there is an anesthetic. Okay. Record the visual acuity, very, very important, without pinhole and with pinhole. And again, use a strong light. Assess the adnexa for any injuries. See if there are any foreign bodies. Ear ophthalmos, exophthalmos, we want to know the orbital compartment syndrome. And ocular motility in all the cardinal positions of gaze and pupils for RAPD. Then come to palpation. Now don't try to palpate put in a speculum. So make sure before first palpate the orbit and then use a lid retractor or speculum with topical anesthesia and assess the IOP. You may need to do a Siedel's test, but a little more detailed examination with slit lamp or a fundus examination you can do a little later. And a gonioscopy, you have to decide whether you want to do it emergently or not. Suppose you are thinking or there is a foreign body in the angle, you may require to do a gonioscopy. So detailed examination can be done a little more comfortably. Do you need to go for emergency imaging? Yes. When you are in casualty, sometimes if you're suspecting an optic nerve injury, they do an emergency ultrasound to see the edema. That is possible because that is immediately available. That is one reason. And of course, if you're globe, you are suspecting an occult rupture, you may need to do, if you have a casualty ultrasound, at least it's not contraindicated, you can do it gently. But MRI, of course, you should, if there's an intraocular foreign body, do not do it. And urgent CT head, when do you do? When you suspect this vision is suddenly decreasing. Patient is going into, we have had cases where just a little bit of edema, but patient's vision was totally out of proportion. And what was the reason? There was a superior subperiosteal abscess, which was pressing upon the optic nerve. So it goes rapidly into PL negative vision. So there you will have to plan for a CT, emergency CT. So this is the ocular trauma score. This only gives the prognosis. All this is in the book, but these are the various sums. Ultimately you get, they are called raw points, and that's how you suspect it. So it's just basically severe injuries there. Now some special conditions, suppose the patient is unconscious, how to do a doll's eye movement, all of you should know this. All of those who have done post-graduation in casualty will know how to do it. Patient will obviously not listen to your commands. You have to move the eye, the head in all directions, and the eye should move to the opposite. There are patients who are totally unconscious. You move the eye in any direction, the eye looks absolutely straight. So that is brainstem injury. If the eyeball is not moving, you have to suspect a brainstem injury. Then third nerve palsy, if there is one-sided third nerve palsy, look for the pupil. The initial third nerve palsy would give a constricted pupil. If it is dilating, then you have to remember that this is uncal herniation. One-sided compression with uncal herniation is constriction followed by dilatation. This is a serious emergency. You have to inform the neuro people that they need to go in for surgery. Some special consideration in pediatric, of course, it's an unreliable history. Again, never force anything from the baby. the child will not cooperate ultimately after that if you do anything which is forced. So you may need to go under an examination under anesthesia. Remember, even if you pad the eye in a very small baby, you are likely to induce amblyopia. And always remember, if you see a retinal hemorrhage like this, bilateral severe retinal hemorrhage, this is most likely to be a battered baby syndrome. There is no other way you get such bad hemorrhages, both eyes. Now, how to assess a totally small baby? Either you place the head in both your hands and straddle the legs. Or you can do the same, the mother holds it like this and you sit on the opposite side and look at the baby's head. So that is one way. If they are fit enough, you can put them on the slit lamp or a handheld slit lamp. Seat comfortably. Talk to the baby. Examine the important parts first, threatening later. And remember, even a small hematoma there may be due to a roof fracture. The child's baby is quite fragile. The bone is quite fragile, and pencil scissor injuries, small penetrating injuries may be seen. So the take-home message is treat the serious injury first. Record the presenting vision. Neurology observation required. Do not dilate. Make the patient comfortable. Document all findings and avoid excessive tissue manipulations. Thank you very much.
Great introductory talk to start the trauma IC. Next we have traumatic hyphema practice pearls by Dr. Ladiga Vasu Kamala Devi.
Thank KSOS and Dr. Raghu for this opportunity to talk on something we all see every day in our daily practice, not every day but quite frequently, and which can be quite vision threatening if not managed properly. So I'll be focusing not on hyphema in totality but just practice pearls. And I'm going to go about this talk in the format of frequently asked questions we all ask ourselves during practice, and nobody else will answer it for us. We have to be knowledgeable enough. So I hope this session helps. And this talk will be basically on tips to put theory into practice while we manage patients. And I'm just picking out some pearls from practice. So the first question is, sometimes we have patients with severe bleed in the eye, and even when we ask a history, there is hardly any trauma. So can a trivial injury the patient even might have forgotten really cause a hyphema? That's the question. So mostly the cause of hyphema is trauma, especially in young males. But if you see hyphema with no or history of only very trivial trauma, always suspect rubeosis. Patient may be having rubeosis, and for whatever reason. So you should be having all the reasons for rubeosis in your mind while you examine the patient over days. And also some rare causes like juvenile xanthogranulomas in children especially, and iris tumors, etc. can also be suspected. Now regarding what exactly to ask, where to focus in your history, the trauma detail we all ask, but recording is also important. Whatever history you ask, remember to record it correctly, because this may be medical legal case histories. And in the ocular history, we apart from whatever we normally ask, focus on any underlying glaucoma, Fuchs iridocyclitis like history, and a history of amblyopia, because Fuchs iridocyclitis can present with spontaneous hyphemas. Glaucoma, as you know, makes the eye more vulnerable to hyphema damage, so does amblyopia. And in the medical history, always ask for anemia, blood disorders, and history of anticoagulants, chronic liver diseases and kidney diseases, because these affect both the prognosis and treatment of hyphema. Now just certain things that you do's and don'ts. Basically, always assess, not only assess but record vision and associated ocular injuries. One injury does not rule out another. So always assess for associated ocular injuries and grade the hyphema quantitatively. Indirect ophthalmoscopy is always a better option because it's brighter. And tonometry, whatever method you are using, be very, very gentle about it if you are doing it. Gonioscopy in a hyphema, it's better to consider only after 1 to 2 weeks. And ultrasound, even if it's a whatever, if you feel it's an emergency only, you do it, and that too very, very gently. You have to speak to the radiologist on it if the radiologist was doing it. And now how to grade, we have many grading systems, but I usually use this grading system. That is, grade 0 means microhyphema, just a few cells or RBCs in the anterior chamber. Grade 1 means 1/3 of AC, grade 2 1/3 to half, grade 3 more than half, and grade 4 is a total or 8-ball hyphema. So these are some other grading systems, but that's okay, we'll focus on the first. So this is first one is grade 1, second grade 2, third grade 3, and last is grade 4. Now once you see a hyphema, we are always taught to admit patients with hyphema. That's what we generally do. And the question is, bed rest വേണോ, head rest മതിയോ, eye rest മതിയോ, ഇതൊക്കെയാണ്. പക്ഷേ mostly it is that quite some ambulation for absolute necessities is okay, but you have to admit, it's mandatory to admit in children. For example, a patient who has a raised intraocular pressure, patient whom you feel there is a tendency to rebleed, and if it's a delayed presentation, already 4 ദിവസം കഴിഞ്ഞിട്ടാണ് വന്നത്, 5 ദിവസം കഴിഞ്ഞിട്ടാണ് വന്നത്, ഹൈഫീമ അപ്പോഴും നല്ലോണം ഉണ്ട്, better to admit that patient. And of course, in any case of penetrating trauma associated, you need to admit. One-eyed patients, you need to admit. So these are certain mandatory admissions that you need to read. And please keep in mind that most rebleeds occur in 4 to 6 days of onset of hyphema. Now, while doing labs, apart from all these other things due to obvious reasons like bleeding disorders, etc., please remember to do a renal function test and liver function test, because you may be using medications sometimes in hyphemas. Now the next question is to patch or not to patch. It's really not a must. Even if you patch, a plastic shield may be good. During sleep too they can use it, and it's practically to prevent further trauma and to make sure that the people rest properly. അല്ലാതെ അതിനൊരു ഡയറക്റ്റ് എഫക്റ്റ് ഉണ്ടായിട്ടില്ല. And also there is this theoretical advantage that in long-standing hyphema, a patch can prevent light-induced endothelial damage to the cornea. എങ്ങനെയാണ് അതുണ്ടാവണേ? This is the mechanism. That means these porphyrins, in a long-standing hyphema, hemoglobin becomes porphyrin. Porphyrin photosensitizes the corneal endothelium. So when light falls on it, it can produce endothelial damage, and that can predispose to blood staining. So this is what you are preventing with a patch theoretically. Although long-standing hyphema. And what is the ideal treatment regimen? This is the usual treatment regimen. I think we all use this only. That is prednisolone acetate for the associated inflammation, atropine. And if IOP is high, these are the treatment regimens. Please avoid pilocarpine, like prostaglandin analogs. And acetazolamide and ivimantol, usually it is needed. സാധാരണ അവർക്ക് IOP hike ഉണ്ടാവും, but usually it is needed. Maybe acetazolamide, not always mannitol. And please remember, only paracetamol is good for pain. Avoid not only aspirin but also NSAIDs, which belong to the same class of medications. Systemic steroids actually is a very good thing to use in hyphema, because it can stabilize blood ocular barriers and prevent inflammation, and also prevent rebleeds. So systemic steroids can be considered in severe cases, especially when you're suspecting rebleeds, and it is as effective as other drugs like aminocaproic acid. That is what evidence says. Now we are all scared about secondary glaucoma. So who exactly are at risk, and how does it happen? It happens in a few days because of mechanisms like RBC or inflammatory cells blocking the trabecular meshwork or pupillary block. In the intermediate phases due to the Gosel glaucoma, and later on due to things like trabecular sclerosis. And those with large hyphema and 8-ball hyphema, etc., are at more risk. And can IOP be low? Yes, it is ominous if IOP is low in a hyphema, because in an acute injury, if you have hyphema, you cannot see anything else, and the IOP seems to be low digitally. Always suspect an occult rupture of the globe or an underlying RD, which you cannot see at that particular point of time. And even otherwise, IOP may be decreased due to ciliary shock a few hours after injury. So you need to monitor IOP daily, because IOP is not a constant. It fluctuates in traumatic hyphema like this. For example, in the first 6 to 18 hours, the thing usually occurs as a moderate elevation due to trabeculitis. അതേസമയം നമ്മൾ IOP medications ഒക്കെ സ്റ്റാർട്ട് ചെയ്യും. പക്ഷേ സെക്കൻഡ് ടു ഫോർത്ത് ഡേ ഒന്നും ചെയ്തില്ലെങ്കിലും ആക്ച്വലി the cause is that it comes down to normal because trabeculitis subsides and even hypertonia occurs because ciliary shock can occur. And then in the 5th to 6th day, there is a gradual increase of IOP because IFEMA is still there. The mechanisms of outflow are not in place, but ciliary shock is over, ciliary body is returning. So that's why gradual increase. And finally, IOP normalizes over around 2 weeks because of IFEMA resolving and these things coming back to normal. So what I mean to say is, even normally this is the profile of IOP, it keeps changing, so you need to adjust your IOP medications accordingly and monitor. Now ghosal glaucoma is a rarity. If vitreous hemorrhage is associated, you know the reason. That is hemoglobin comes into the anterior chamber from the vitreous, becomes ghost cells which are non-pliable, they contain Haynes bodies, etc. This is all theory. So coming to the complications, rebleeding, glaucoma and corneal blood staining are the usual complications, and you just need to identify who is at more risk of rebleed and act accordingly. So total hyphema, markedly low vision at presentation, delayed medical attention, people using blood thinners, and increased IOP or hypotonia and sickle cell trait. These are the things you need to detect and treat. Now, how do you know that this patient is going in for a rebleed? If your hyphema is becoming layered, that is the size is increasing, or a layer of fresh blood clot is happening over the darker clot or in the periphery, then you should suspect that either there is a rebleed coming or a clot lysis is beginning. That is the time when you may have to think of things like aminocaproic acid. So that's the mechanism. Let's forget the mechanism, but aminocaproic acid produces a lot of side effects, so don't use it in renal failure, DIC, allergy, etc. Instead, even systemic steroids are very good. So in my practice, I use systemic steroids. In such patients, I don't use aminocaproic, but I do use sometimes tranexamic acid, especially in diabetics where I cannot use systemic steroids. Okay. Now, corneal blood staining is a much less occurring complication. I'm not going into the theory of it, but just remember that patients with large hyphema, prolonged clot duration, sustained IOP elevation, and endothelial compromise as in a Fuchs dystrophy, these are patients who are at more risk of, and how to detect it. See, it occurs as a yellowish discoloration, but that yellow reflex can occur even in absorbing blood. So if your yellowish discoloration is occurring in the center first and it is markedly increasing from the center, then it may be corneal blood staining. So when to discharge a patient with hyphema? So you have to daily monitor these things, the size, IOP, etc. At least 4 to 5 days you wait, because you cover that rebleed risk. And then if it is stable and if hyphema is less than half, you can discharge according to patient compliance. Now, when to intervene surgically, we know all these IOP parameters. In sickle cell trait, it is more vulnerable, you need to act more early. And blood in AC, if this is important. Total hyphema, we don't discharge anyway. We intervene in total hyphema in 5 days. But hyphema persisting more than half, the AC for more than 8 days, again you think of washing it out. And surgical options, these are the surgical options. Just a word about sickle cell disease, because you need to intervene earlier. So always admit in sickle cell disease, close monitoring is needed. Avoid acetazolamide, avoid mannitol for reasons, because it will induce sickling. And timolol, mannitol is the last resort, and earlier surgery may be needed. So these are some of the pearls from practice. Thank you for your kind attention.
Thank you so much, ma'am. The question answer format was very interesting presentation. Next we have Dr. Sujata Nambudri on traumatic optic neuropathy.
A brief overview of our current understanding of this topic and where we can make some difference. So as we all know, this condition is a vision threatening condition which is affecting the most active or visual economically contributing segment of our population. That is, young adults in 20s and 30s are affected, males being more common, And the road traffic accidents and falls are the contributing factors. They also they contribute about 0.5 to 5% of all trauma cases. In a patient with severe head injury, an established TON or a subclinical TON may be easily overlooked. That's what we saw in the study done in 2024 in Government Medical College Thrissur, where 179 patients were studied who were admitted in the ICU with closed head trauma, and we found that about 6.7% of the patients had TON. So this is the anatomical classification according to the part involved. I am not going to the detail. But what is more important is the type of the injury, that is whether it's a direct injury directly affecting the nerve or it's an indirect mechanism. And direct injury being due to the direct trauma to the nerve due to a bony fragment or a foreign body, or as you can see in a severe head trauma which directly injures the optic nerve also and produces severe and sudden visual loss, and the prognosis is very poor. The indirect traumatic optic neuropathy can be an anterior one or a posterior one. Anterior one if it is involving the part of the optic nerve anterior to the central retinal artery where visual loss is instantaneous. But commonly we have a posterior indirect traumatic optic neuropathy, where that is in the intracanalicular and the intracranial parts are being more involved. And that is due to there is no direct injury, but injury is due to the bony structure, that is trauma to the temple or the forehead, and the pressure waves are transmitted posteriorly and are concentrated around the optic canal, producing a shearing effect on the more fixed part of the optic nerve, that's the intracanalicular or the intracranial part. Here the vision loss can be immediate or can be delayed. So, few words about the pathogenesis, that is to understand the treatment. So, there is a concept of primary injury, that is basically due to the ganglion cell death caused by the shearing effect of on the optic nerve axons, and also contusion necrosis due to the ischemia produced by the pial plexus. This part of injury cannot be reversed. So, that's why many patients we get a very bad visual acuity at presentation. But there is a secondary phase of this injury that is caused by the vasospasm, swelling of the optic nerve within the optic canal, and injury due to the free oxygen radicals. And the rationale for steroids is that they prevent this secondary injury. So, what we should keep in mind when you approach a patient with TON is that we need to take a meticulous history that includes if there are any what's the mechanism of the injury, is there any history of loss of consciousness, any history of raised intracranial tension, bleeding from the ear, any clear fluid coming from the nose. In all these things we should be very cautious in starting steroids. So, the initial visual acuity should be recorded because it's a great prognostic factor, but it may be very difficult in a patient with altered sensorium. Most important clinical feature of a unilateral TON is RAPD, and it goes to say that if RAPD is not present, it's not a unilateral TON, but maybe very rarely it may be due to a bilateral TON. And the presence of the ipsilateral dilated fixed pupil, if you have a third nerve injury, also provides a challenge. But if you watch carefully in the other eye and demonstrate the decreased consensual reflex, that will clear the doubt. Color vision contrast sensitivity will be essentially low. You can get any type of field effects, but usually in posterior TON, the optic disc is normal. Then investigations like neuroimaging are not compulsory to start treatment or to assess prognosis, but they will tell you they will delineate the type and the site of the injury, and very important medical legally. So, CT scan is a better adjunct to detect a patient having a suspected or an established TON, because they demonstrate all the bony fractures clearly and also intraorbital or intraocular foreign body. But if you suspect a soft tissue injury, you may, like in a hematoma, you may need to do a MRI. But there is no consensus regarding the demonstration of the optic canal fractures and the visual recovery in the literature. And VEP is only required if there is a bilateral TON or if there is a progressive reduction in vision in the first 2 days. And gross reduction in the amplitude of the affected eye is a bad prognostic factor. Going to OCT, at presentation usually appears normal, but you can demonstrate ganglion cell loss or nerve fiber layer thinning within 6 to 8 weeks later. Field effects, it is ideal to take field of both eyes because rarely you may have a severe trauma involving the optic chiasma also. Inferior altitudinal defect corresponding to the superior part of the optic nerve involved is the usual or the commonest field defect. These are the bad prognostic features. So before we try to manage TON, as previous speaker had told, we should treat the life-threatening and other vision-threatening injuries like a rupture globe, hyphema, or other injuries. Then the challenges in treatment of TON are due to absence of any large natural history studies or randomized controlled trials which tell you about how to treat TON. That may be because these studies were not possible in such patients who had already other severe problems. Or maybe it is due to they are very rare in the Western population. So these are the modalities of treatment available. And a confounding factor is that spontaneous visual recovery is reported in 40 to 60 patients who are treated conservatively, that is comparable or even superior to the other modalities. Lateral canthotomy or cantholysis may evacuate all the blood and decrease the intraorbital hemorrhage. The ideal surgical treatment is a optic canal decompression, that is a transnasal endoscopic decompression is the ideal or the preferred technique. And these are the indications such as hematoma, foreign body, or a documented progressive visual loss in the first 24 to 48 hours. Again, there is conflicting opinion regarding the superiority of the surgical approach, and no RCTs are available. And we should always keep in mind the serious complications that can occur. So let's move on to the most common method of management we all adopt, that is the steroids. Here, steroids are thought to prevent the secondary phase of the optic nerve injury, and to be effective, they should be started as early as possible. So the rationale for using steroids was first studied or based on the results of the second national acute spinal cord injury study, and more randomized study was the international optic nerve trauma study. They told us that 52% of the patients with steroids improved, while only 32% of the patients with surgery and steroids improved. But still, there is 57% who improved with conservative management. So, but always we should keep the crash trial results in mind, that you should not start steroids in patients with severe head injury because it will worsen the cerebral edema and even cause mortality. So this is increased mortality. So this is the current consensus, that is injection of methylprednisolone 250 milligrams 6 hourly and maintained for 24 to 48 hours. And they say that it should be started within 8 hours, but this window period is usually even extended up to 2 years. And we practically give 1 gram IV per day, 3 days, and then follow it with tapering of the oral steroids. But before starting the steroid therapy, we need to have a medicine or a neurosurgery fitness, and ideally we should collect an informed consent. Moving on to the recent method of treatment, that is erythropoietin. It is supposed to reduce the apoptosis of the retinal neurons due to the trauma. And this traumatic optic neuropathy treatment trial compared erythropoietin, steroid, and observation, and showed that erythropoietin also has significant improvement in BCVA like the other two modalities. And we have a Indian study, although it's a pilot study, with similar results, and they also tell that erythropoietin shows lesser and no side effects. More studies are going on related to erythropoietin, but this current study reports the increased trial of different increased dose of erythropoietin, and had found that there is no no superiority to increase the dose and to prevent further damage. And this brings up to the future avenues of therapies like glutamate antagonists, now growth factors, and so on. So to conclude, I would like to say that the diagnosis is timely, should be important. Most important is that you should monitor a patients with severe head injury, not only to detect TON, but also to for detecting, and also worsening of the TON. There is no accepted gold standard for treatment, and you can have the treatment can be individualized, and it's always ideal to take a informed consent before the IVMP and get a medical and neurosurgical consultation before starting the treatment. Thank you.
As Dr. Sujata said, sometimes we miss the optic nerve injury. We had a very interesting case, one dog bite. One child was held by the dog, and then the father pulled off the child, and we found a lid injury, and we sutured it after 24 hours, and then after that we noticed this child has a dilated pupil and PL negative. So we kept wondering what was the reason for this. Finally, we realized that there is vitreous hemorrhage, but that also we didn't know what was the reason. And then we referred to retinal surgeon at Giridhar Eye Hospital. They did a vitrectomy, and they realized this child, because the father pulled the child back, he had an optic nerve avulsion. Oof, it was terrible. Bitten by the dog, the child in the jaw of the dog, and father pulled him back. And that led to, so it's something which can happen in all kind of trauma. So, thank you. Now to the next interesting topic on medico-legal aspects by Dr. Raghu himself.
Thank you, ma'am. Thank you, KSOS, for the opportunity. So, the medico-legal aspects of trauma is definitely important. So, this is a brief outline of the presentation. So, in a paper regarding this medico-legal aspects in an epidemiology, I saw that more than 75% of affected were males, and the age was 7 to 75 years. Bilateral in 15% of cases. Most common type of injury was closed globe injury, and contusion with fist was common cause. And in open globe injury, it was penetrating eye injury. And rural, over 90% needed surgical intervention, and 90% the final outcome was less than 6/60 or legally blind. So, we know the legal implications of ocular trauma can lead to severe legal consequences, necessitating a thorough understanding of the legal framework surrounding such cases, and the importance of documentation and reporting cannot be overstated. So, we have what are the medical legal cases is vital. We have to understand what will constitute that, and we have to understand our own legal duties as ophthalmologists, including how to report and how is getting the obtain the informed consent and all. So it was the last outgoing president's project, this medico legal thing, and as part of that, yesterday the Sammada Patram in Malayalam was released in the inaugural function. We saw that. So because it has to obtain from the patient in written in patient's own handwriting and own word. So or they can be asked copy, but in own language. That is why it's important to have this in prior in our own language. And the evidence preservation and chain of custody. So this is a concept. So we have to properly handle the evidence, and the chain of custody is required to ensure that the evidence remains admissible in the court. So there should not be any tampering with or any contamination, etc., so that the evidence is not destroyed. So in ocular trauma, there can be various situations, mainly assault, road traffic accident and occupational injuries. So all of this will lead to a medical legal case, and the routes. So you know the rules how to do it, like how the police intimation and all. So in government institution it is a usual thing, it's an easier one, but in private also the first doctor who sees if it includes any of these previous situations, then they have to maintain that medical legal, register, and also write an MLC, and also have to give police intimation. So in government the police may come time to time to collect it, but privately have to send to the nearby police station. uh, and if you are referring, you have to keep it very properly, that all the documentation, and maybe even get it in writing from the patient and the bystanders that they were referred for further treatment. So common scenarios can be penetrating injuries, thermal burns, etc., and different types carry different legal consequences. So the duty of the care, that we have the legal and ethical duty to provide immediate treatment in emergency situation even before a medical legal case is registered, because first important is to maybe do something to save the vision or save the life, etc. So first, most important thing is to give the care, and then we will have to definitely take care about the MLC reporting process. So certain injuries, particularly those resulting from violence or accidents, must be reported to the appropriate authorities, but the patient confidentiality need to be maintained also. So the documentation, essentially we all know, for example, wound certificate need to be given, and it has to be very thorough, meticulously written. For example, once when someone went to the court, the question was, why haven't you written the modus of operandi? So such things can happen. And so use of imaging and photograph, nowadays it is especially emphasized that you take the picture, if you have like good satellite photography, etc., well and good. Otherwise, at least in the mobile phone, if you take the photo and keep it for yourself, also the OP ticket. Many times in government setup and all, we only thing we have is that OP ticket, and it is given away for the patient, where there is no EMR, and we are giving to the patient. Sometimes the things go to the court, the patient may not simply produce it to the court, or will say that it was lost or nothing was given. So if you know this is going to be an MLC, better take a photo in your phone and keep it in a separate play. And how long should we keep such things? So non-MLC 3 year, MLC 7 years, something guideline is there, but it's better to be kept indefinitely, because you know this cases can go for years and years, 10 years, 15 years, some cases go. So better such things keep indefinitely with you some way. So then regarding from informed concern we just told, so we have the, wherever possible, a clear communication of the risk and benefit of the treatment is essential, especially for enucleation and etc. So I think, Sujata madam, can you tell about that incidents when 2 eyes were enucleated in government medical college Thrissur?
Actually, 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 it was not enucleated. The patient had, at the time of COVID, and patient had admitted in the surgery department for trauma and secondary infection, and there was septicemia, gross septicemia. The patient was not expected to survive, and so much antibiotics, IV antibiotics and interventions were given. So they presented with panophthalmitis in both eyes, severe, and then that with the concurrence of the surgical, other treating surgeons and other, and we had to do evisceration in both eyes. But he was a very young 30-year-old person. So even though he was seriously sick, he recovered. And then it was our problem only.
Thank you, ma'am. So since he recovered, and they were telling that, see, now I am totally blind, and because of you people I am blind, so they gave all the case. But ultimately everybody told that it's clear the decision by the doctors were right. So anyways, we have to be very careful. 2-3 times in such cases, 2-3 doctors have to give the consent. So all this protocol we have to do very meticulously. So and so there is this importance of preserving the evidence, foreign body clothing, etc., and the custody chain of custody already I told, and evidence mishandling can jeopardize legal cases and lead to unfavorable outcomes in the court. So we have to know these things. So trauma classification is better to use properly. So this Birmingham eye trauma terminology we all know. So it's better to use such things, or ocular trauma score, etc., because accurate classification of trauma can significantly influence the legal outcomes. So we should, how to prepare the medical legal report. A well structured report must be factual, objective and clear, and avoid speculation. It should not have any doubtful terminologies, and key components include patient identification, history, examination, finding, etc., and there should be clear and objective reports. Only they can have credibility in legal settings. Precise language reduces the risk of misinterpretation. For example, grievous injury in section 322. So when to say grievous or simple. So in ophthalmology, if there is a permanent loss of vision of either eye, or permanent disfiguration of head or face, lid, eyeball, orbit, etc., or there is a fracture or dislocation of a bone or tooth, in our case orbital bone, or it endangered the life or keep out of employment for more than 21 days. So these come under grievous injury. So when you go to the courtroom, mostly you are taken as an expert witness. There you have to stick strictly to the fact, avoid giving options outside specialty, and there is an importance of preparation. Better prepare and go, so that there see the cross examinations where the advocate will try to get something wrong out of your mouth. So regarding consumer court, there is that act COPRA 2019, and it considers if you are they are paying for the service, so they are considered consumer, and they can give a complaint against an ophthalmologist based on medical negligence, which three elements must be established: duty of care, there and breach of duty, and causation and damage. So so some case studies. Ravi Teja Vishakhapatnam case. So there was an air rifle pellet injury, and the hospital failed to remove all the pellet fragments initially. So subsequent treatments revealed remaining fragments, leading to visual loss. So the principle of res ipsa loquitur, that this thing speaks for itself, was applied. So they said there was clear negligence, and 15 lakhs compensation was given. VJS hospital claimed injury was 2 days old and emergency treatment was provided when diagnosis facilities were unavailable. But so expert committee found no prima facie negligence, and the court dismissed the complaint. This case highlights the complainant's burden to prove the negligence and the importance of expert medical opinions in dismissing claims. So if we are documented clearly and we say that, so it depends on the consensus and whether the standard of care was given or applied. So not related to this, but in another case, so someone with 6/18 vision cataract operation was done and developed some complication. So at the court, another expert told that 6/18 there was no need to have operated, and this that doctor told that, ophthalmologist told like that, and so the court went against this doctor and gave a huge fine. So this usually the standard of care, whether it was given, is what is checked, and that depends totally on lot of expert consensus and the research. So another case, Abdul Jamal versus MOSC hospital, eye injury from a flying piece of nail in Middle East. Conservative management for 1 month was given. Later there was an intraocular foreign body which is found in Arvind, Coimbatore, and for this lapses like no imaging, delay in referral, and lack of documentation of referral. For these things 2.5 lakhs was given. So these are the happen. So we should know that we should, even if we don't have imaging, we better send for imaging as a defensive medicine, we can say that, or better refer it, then there is no issue. Another case, Mahatma Gandhi Institute of Medical Science versus Srikanth Singh Kushwaha. So there was an injury from an iron strip, and the hospital failed to detect small intraocular foreign body during the initial treatment, and subsequent examinations revealed the intraocular foreign body causing complications like vitreous hemorrhage and glaucoma. So failure to perform an X-ray to detect the intraocular foreign body was deemed as a negligence. Another case, Navajyoti Eye Care. So right eye had a iron rod, initial treatment followed by surgery, and dismissed the complaint finding no negligence. So here the prompt referral, initial trauma, so if they adhere to the acceptable standards, so okay, there is no issue. So just one last thing. So IMA professional protection scheme, everyone will be knowing. So initial starting 2,000 rupees per year, they will give 10 lakhs indemnity insurance. They even have in Supreme Court advocates who takes it per sitting 1.5 lakh. Such advocates are with them, and they will be in our service for just 2,000 rupees. So it's a very beautiful scheme, and you can add on protection for 10,000, add on up to 1 crore indemnity insurance. So if I hope most of them have it. If you have, so if some legal action comes, never panic, inform the district representative of the scheme, and they will take care of it. Okay, so ignorantia juris non executat. Ignorance of law is not an excuse. Thank you. On traumatic glaucoma.
So, good evening everyone, and thank you Dr. Raghu and KSOS for the opportunity. And regarding epidemiology, trauma, as you know, is more common in young males, and in the mechanical injury, closed globe injury is most common. It is 77% and open globe injury is 23%. The issue with any traumatic glaucoma is that most of them are unrecognized because people forget about their old trauma and the diagnosis gets delayed, and this is one of the cause for preventable glaucoma. Predictors for glaucoma development include poor initial visual acuity, advancing age, the presence of lens injury. Angle recession is one of the most important parameter, 180 more than 180 degrees, higher baseline IOP, and presence of hyphema. Classification of globe injuries are like mechanical, chemical, thermal, and electrical, and most common will be mechanical injury. In that, it is open globe and closed globe, and the causes of glaucoma could be early onset of IOP elevation and delayed onset. So, the most common cause of an IOP elevation and glaucoma could be the large percentage is because of a mechanical trauma. The direct impact leads to change in shape of the eye. What happens is that the anteroposterior globe compression happens. There will be equatorial scleral expansion and limbal stretching, and this stretching is what causes problem. Posterior displacement of lens iris diaphragm, sudden IOP rise, and splitting or tearing of tissues happens. These are the 7 rings of Campbell that is important. What you see here is this the iris sphincter, that tear happens, the sphincter tear. Iris base, what happens is the iris dialysis happens. Anterior ciliary body, the angle recession, where you see the longitudinal and the horizontal fibers splits, and the ciliary body, what happens, cyclodialysis cleft, what happens is the cleft develops. I will come to that subsequently. So, trabecular meshwork tears or zonular dialysis can happen, and also retinal detachment and retinal dialysis can happen. Early onset, what happens, the IOP elevates because of, first thing is inflammation, trabecular meshwork disruption, and also hyphema. Major reactions from trauma that leads to high IOP is because of secondary to outflow obstruction, trabecular meshwork inflammation. This outflow obstruction can be because of inflammatory cells, debris, or protein. Usually it is self-limited. Close monitoring is required. Acute suppressants are given. Topical steroids and cycloplegics are required. Trabecular meshwork disruption are usually missed because it is a subtle finding that you could see. It can lead to early and late glaucoma. Careful inspection and always bilateral comparison is required with good gonioscopy. It could be coexisting with inflammation, and definitely hyphema and recurrent hemorrhages can happen. Hyphema, madam has already covered, isn't it, ma'am? So, most important thing is like whenever you see that early signs of corneal staining, that immediately needs to be identified. Never leave the patient to be in this stage of corneal staining, and this is something that you never want. Delayed onset of glaucoma, that is very important because patients usually forget that history of trivial trauma that they have had. Angle recession glaucoma is the most important thing in that. It is a common cause of glaucoma after contusion. The visible marker of invisible trabecular, we are not looking, angle recession is not the cause for glaucoma per se. It is the invisible trabecular meshwork damage that has happened. That is the cause for glaucoma. The when there is an angle recession, almost always there is a hyphema that is present, and in not every glaucoma angle recession leads to glaucoma. Just 7 to 9% leads to angle recession glaucoma, and when you have more than 180-degree involvement, that is when you usually get a angle recession glaucoma. And a most important thing is that these people are genetically predisposed to primary open angle glaucoma. Other eye also later might get a POAG. So these people are also to be on follow-up. This could be because of the IOP elevation, and glaucoma could be because of increased outflow resistance. The scarring happens in the trabecular meshwork, and there could be a membrane formation. It is an always an open angle glaucoma in angle recession. If at all a synechia forms part of healing. Signs of recession, hyphema is an indicator. Immediate gonioscopy is usually not preferred. Earlier we used to tell about 4 to 6 weeks it is deferred and all, but nowadays when you do that, not do that indentation gonioscopy, and it is not as traumatic with the four-mirror gonioscopy, earlier you can do, but let it immediately with the high presence of hyphema, you are not going to get that much of findings. The meticulous evaluation, it has to be bilateral comparative. It is always comparative gonioscopy that gives the findings. Signs of recession, the broad ciliary body band, the broken iris processes, and the abnormally white scleral spur happens because of the torn iris processes. So this is ASOCT, and ASOCT here what you see is that open angle, and just a minute. So this is a diagram that shows the normal attachment of scleral spur and the iris. There is a split between that is a scleral spur there, and this is the longitudinal fibers, and these are the circular fibers. A split there is what is called an angle recession. So that medical management is in the similar lines: lowering IOP, aqueous suppressants, prostaglandin analogs bypass the dysfunctional trabecular meshwork, so it is better used. Myotics paradoxically increases the IOP. ALT and SLT is not useful in ankle recession because the trabecular meshwork is damaged. And surgery, usually what studies have shown, the surgery has little more risk for failure. But it is the same way as other open angle glaucoma is managed. Other glaucomas that happens is because of the intraocular hemorrhages that can happen. Ghost cell glaucoma is happening because there are ghost cells. Those are the khaki colored cells because of the degenerated RBCs. Long lasting vitreous hemorrhages leads to degenerated RBCs, which comes and occludes the trabecular meshwork. And these are small uniform fine khaki cells, and they have tan colored hypopyon, that's called pseudohypopyon. Fresh hemorrhage layered by this tan colored hemorrhage is called candy striped sign. This is again medical management, and if the vitreous hemorrhage is severe and the glaucoma goes uncontrolled, you might need to do AC lavage and vitrectomy. Hemolytic glaucoma, it is a secondary open angle glaucoma days to weeks after intraocular hemorrhage. Here what happens that hemoglobin macrophages that free hemoglobin and all those remnants clogs the trabecular meshwork, usually related to large intraocular hemorrhage. What you see is that on gonioscopy is the trabecular meshwork is reddish brown. The trabecular meshwork is occluded by the RBCs. Here refractive cases we might need to do AC lavage. Hemosidrotic glaucoma, what happens is that the iron content of the RBCs gets lysed and the iron gets released, and this iron goes and damages the trabecular meshwork endothelial cells, and those scarring and degenerative changes, sclerosis and obliteration of intertrabecular spaces leads to glaucoma, and that is a hemosidrotic glaucoma, and it is usually associated with other features of sidrosis. Hypotony happens for post injury, that in the acute phase is because of decreased aqueous production or increased outflow due to inflammation, and it can also happen because of what is called as cyclodialysis cleft. It is when you do gonioscopy, it is important to differentiate between a cyclodialysis cleft and a angle recession. Cyclodialysis cleft is seen as a white area of scleral spur that is clearly seen. Ciliary body is torn from the scleral spur. This importance is that the ciliary body is detached, and then there is a direct communication from the anterior chamber to the uveoscleral space, and this leads to hypotony. And when you when some PAS forms, or when you close this cleft, it might lead to ocular hypertension later. And this is an example where you can see that the trabecular meshwork, the scleral spur and the iris root has detached, and there is a communication. And here again, you can, in the ASOCT, you can see that cleft here. That is a Bayer's sclera, and that space is a cleft. So, penetrating injury 2.67% leads to glaucoma. Is usually advancing age, lens injury, the baseline visual acuity, inflammation, pre-existing anomalies, all tells about the prognosis. The structural alterations, blockage of trabecular meshwork is a pointer. Again, we should always remember about this parameter of epithelial ingrowth, epithelial downgrowth and fibrous ingrowth that might also block the angles. When there are intraocular forward in body, this sidrosis thing and the chalcosis also has to be remembered. In chalcosis, the glaucoma is usually little rare. Chemical burns can also lead to glaucoma because of tissue shrinkage and disruption of the trabecular meshwork, and this lead to chronic inflammation. Trabecular meshwork is affected because of the inflammation also. Ciliary body necrosis can happen in alkali burns. After the most important thing is treatment is difficult after a chemical burn because the conjunctiva is scarred. So any glaucoma surgery ideally depends upon the conjunctival health. Nowadays mix and all are coming up where conjunctiva is spared, but routine glaucoma surgeries are conjunctiva dependent. Thank you. Just wanted to show this case where every finding possible in trauma is there. That is an iris hole there. That's an ASOCT picture. That is a PAS that is in the yellow round. And this patient had both this, that is the angle recession over there and cyclodialysis cleft. So one patient with all the findings. Just that. Thank you.
Thank you, ma'am. That ends the session. Thanks everyone for coming.